Welcome everyone to our series, ECHO, Nutritional Integrated Intervention for the Management of Chronic Diseases in Primary Care. My name is Nicole and I'm going to be your moderator, and I have everyone from the Institute of Public Health. So briefly, we're going to be starting, and I want to have some announcements at the beginning. You should all write your name in the chat so that we can identify you, and so that you can also change the name as part of your user ID in Zoom. So those two things, your name, full name in the chat, and changing your name in the Zoom using rename so that your participation certificate is correct when we prepare them. And briefly, I also wanted to speak to you about the Institute of Public Health and what it is. We are a program that is bringing forth this initiative called ECHO that offers a telementoring service. Today, we have the participation of Dr. Hernández Dávila, who is with us today, and she is going to be in charge of one of the presentations. So I wanted to speak a little bit about how this came about, and it's to create a program where we talk about health initiatives and needs in the community through the retention of professional and access to public health services in Puerto Rico. So our goals are to retain health professionals so that we can implement the ECHO model that we're going to be using today, and strengthening the practice community and the quality of service in collaboration with medical offices, public or private clinics, etc. And we want to have more specialists and more quality services uh, collaborating with academic settings, and having a better digital library of services. We have a translation or interpretation service. So you can go to the interpretation area, hit more, and you're going to be able to see the language area, and you're going to be able to hear in English or Spanish with simultaneous interpretation. I want to talk about the general guides of the ECHO session. We invite everyone to turn on your cameras. We want to know you, of course, if the connection is available to you, and you can. We believe in active participation, so you can use your mic and use also the hand so that we can call on you, raising your hand, and you can also share your experiences through the chat throughout the session. Briefly, this is our agenda. I'm going to talk to you about what we're going to be doing. We have an introduction, a welcome, then we have general guides of the project, the ECHO methodology, the credits for continuous education, evaluation, pre-test, academic preparation 1 and 2, a post-test, presentation and discussion of a case, recommendation from the experts, evaluation, announcements, and closing. And this is part of what we see as the ECHO methodology, that we use technology, make the most of it so that we can promote 4 principles. I'm going to pause for a moment so that we can turn the music a little bit down so that we can discuss this more comfortably. So we are back here with the ECHO methodology. This ECHO project has 4 principles, which is apply technology to make the most of winning resources, share good practices so that we don't have as many disparities, study of cases for learning, and dealing with complexity, and we also have a database to monitor the results. And this way, everyone is learning, everyone is teaching because the methodology is yours. And the expert, as well as yourself, are going to be able to share best practices as colleagues, and we can look for solutions based on evidence and improve the quality of care that the patients are receiving. So learning is based on real cases, and we evaluate satisfaction metrics so that we can create a feedback cycle. And right here, I want to invite Alexandra Ortiz, my colleague, who is going to be talking to you about quality improvement. Here you go, Alexandra. Thank you, Nicole. So following up on this ECHO topic where everybody learns, everybody teaches, our team at the Public Health Institute promotes that the experts during the series present applicable practices. And when we are talking about applicable practices, that are those actions, strategies, or tools that are based on evidence that you as health professionals can implement directly in your clinical practice. So during the pre-test and the post-test, we're going to have 2 additional questions about applicable practices that our experts are going to be sharing with us in this afternoon. And that is what we know as quality improvement. In addition to that, we want to mention that one of the benefits that we have during the series are the office hours with the experts on the topic, where if you have any particular doubt, you can coordinate some time with them as long as they are available. And if we can coordinate something that works for both parties. And the last thing is that I want to mention that we have an open opportunity to collaborate in future series. It's collaborating with us in a study where several clinics or health professionals can take part in our series, and we can measure changes in the indicators or markers of your patients, and we can then evaluate the echo model beyond what the pre and post test tell us. So if you're interested in this, you can write to the email address that appears in the screen or call us at that phone that appears at the bottom of your screen, which is our office phone number. If you have any questions, you can also use the chat so that the session can continue in its rhythm. Thank you, Nicole. Thank you, Alexandra. And now you're going to see on the screen the QR code for the pretest. And you're going to see it also in the chat. If it's already on the screen, you can go ahead and work on the pretest. We have certain questions. There are just 8 questions. 5 questions? 8 questions? There are several questions. And we're going to give you a few minutes so that you can answer those questions. And then we're going to go into presenting Dr. Hernandez. And after that, we're going to continue with Keyla, who is a licensed dietitian. So I'm going to give you a few minutes for the pretest. And so I see that some of you are already answering the pretest. Thank you so much. And I'm going to take this opportunity to start with our first presentation of the afternoon, which is nutrition and diabetes. And I want to introduce you to the endocrinologist, Dr. Leticia Hernández Dávila. You are welcome, and we give you the microphone. Thank you so much. Can you hear me? Yes. Let's see if I can. I need to share my screen because it's telling me that my opportunity to do that is disabled. Yes, now you can share your screen, and I'm going to stop sharing my screen. Can you see my screen already? Yes. Okay. So welcome everyone. We're going to be talking about obesity as a cardiometabolic disease. I don't have any conflict of interest to offer this presentation. Some of the objectives of learning are very simple: recognizing obesity as a chronic cardiometabolic disease. We're going to, you see some letters there, A, B, C, D, adipose-based chronic disease. So we are talking about how obesity contributes to conditions that are cardiometabolic in nature. And then we're going to evaluate adiposity and its relationship with a metabolic syndrome, know about the current options for the management of obesity, and identify and prevent overdose and the adverse effects. And when we're talking about the definitions of obesity, if you've seen the presentation before, you've seen these definitions. The most important thing is that we have to recognize that obesity is a condition that is recurring and chronic, and that we have a lot of factors that are going to influence the development of this condition. And it's not something related to a lack of will in a person. And this accumulation in adipose tissue in other places that's going to cause metabolic, psychosocial, and biochronic adverse conditions. These adipose tissue are going to be in places that we're not expecting them to be accumulating, and that's going to bring that mechanical, biomechanical issues. And there's going to be also psychological influences, and we recognize all of this multifactorial determinants in the obesity and how they are genetic, epigenetic, social determinants, psychological, medication, and other medical conditions as shown in the screen. And we know that we need to see obesity more than just a number in the scale or a BMI. Obesity is affecting more than 42% of adults in the United States, and in Puerto Rico's case, more than 70% in adults when you combine it with overweight. So that is a lot of adults. And this is associated with a raise in the risks of diabetes, arterial hypertension, dyslipidemia, cardiovascular disease, premature death, and sleep apnea. And we know that we have an epidemic of diabetes that we need to try to decrease, such as diabetes 2, that we can prevent. And the BMI is not enough. As you saw in the last presentation, you've seen this slide. It's not enough to determine the individual risk of dealing with all of these conditions that we have mentioned before, because the way that the adipose tissue is distributed and what it produces is important to determine risk factors. Several organizations, and this article was published in the Lancet journal, invites to that we use the BMI and understanding that it is overestimated or underestimated in terms of the adiposity of the patient and the complications of the patient. Sometimes we see people that have adipose tissue but have no comorbidities, and others have a lower BMI, but they still have adiposity and they have metabolic issues and psychological issues and quality of life related to obesity. And when we treat the differences in this, it's very important that we understand this when we classify these patients. And so we need to change when we're talking about the practices in these conferences. We have to understand how to evaluate the patient, adding other elements aside from the BMI so that we can classify, evaluate what comorbidities or risks that patient is facing or has been developing and how that affects quality of life. All of these elements uh, aside and from the BMI is going to determine how I'm going to treat this patient, because all obese patients, even if it's a level 1, needs treatment. And when we're talking about treatment, we're talking about changes in lifestyle, including how they eat, how they behave, and exercise, which are the basis of any treatment, all treatments. What other elements are we going to use? That's going to depend on the clinical evaluation that we go and have with that patient. These, I'm not going to go into this because of issues of time, but this is a different evaluation that is dealt with or presented by the European Institute in the study of diabetes, and they reach the same conclusion in 2025. We need to add other anthropometric elements when we classify the patient. We're going to use the BMI uh, as a screening measure, but we need to evaluate with the medical uh, component and the functional deal to be able to classify the patient and determine the treatment that we're going to offer. And what did we find in a balance evaluation is that when we add the BMI, the comorbidity, we see adults that we would classify as overweight, we're going to have to reclassify as obesity because there are metabolic complications that are already present because of obesity. And it's so high in proportion that it might be 79.9 in terms of hypertension, 33.2% of arthritis, 15.6 diabetes, 10.5 they already had cardiovascular diseases. So that location of the adipose tissue, the distribution, the quantity, and what is produced by the adipose tissue is going to be important, because that adipose tissue that is in the subcutaneous area doesn't have that risk and that insulin resistance associated with that adipose tissue that is in the internal organs, visceral fat. And why is this important? Because this production of uh, adipokines, cytokines related to the adipose tissue, right, that are part of another location are going to produce inflammation that is systemic, fibrosis, hypoxia, alteration in the secretion, and they're going to also cause mitochondrial dysfunction that complicates everything, right? Um, Fatty tissue, exarchotic disease, metabolic insulin resistant, type 2 diabetes, cardiovascular disease, because it increases the cellular hypertrophy. When we have a caloric excess, we see that the resistance to insulin goes down. There's a lot more inflammation. There's a lot of more macrophages infiltration, and that brings to a metabolic level complication. And that explains the relationship between obesity and cardiometabolic disease. The American Association for Clinical Endocrinologists also tells us how to reclassify and evaluate these patients, basically first recognizing the same elements that can be part of the abnormal expansion of adipose tissue, and it provokes obesity and classifies preclinical obesity when we don't have defects at an emotional level, quality of life, and we don't have other complications. We can have level 1, level 2, and then we start seeing complications. Glucose goes up. I start using fatty liver. I have hypertension, but I am not considered a hypertensive patient. We could classify this as a level 2 patient, and level 3 would be terminal conditions, diabetes, fibrosis in the liver, and it deals with a more aggressive management. In all of these groups, the American Clinical Endocrinologists Association are going to recommend changes in the lifestyle, exercise, restriction in calorie ingestion, supervised nutritional evaluation by a nutritionist, a registered dietitian, a structured exercise modifications under the behavior uh, issues, supervise if we suspect that there are problems with the food or eating behavior, and we have to evaluate these patients because there's a high prevalence of these conditions, and many times they pass without us seeing them. And then we see patients that have complications if they have a BMI higher than 27 and related complications, even if these are effects in terms of quality of life. And we can consider pharmacology for these or pharmacotherapy in these patients if they have more than 30 BMI, even if they don't have complications. We could consider the use of pharmacotherapy or some more advanced therapies, maybe metabolic surgery to manage this patient. And this slide is the one that I really want you to take away with you. It's this part of changes in how we deal with the evaluation of these clinical issues. And it's what other tools I have to measure the adiposity and better estimate the adiposity in my patients, which is BMI. That's also part of it. We need to, uh, this is very expensive sometimes if we look for the equipment, but we can have a metric band in our office that's accessible to everyone so that we can measure the abdominal circumference if it's higher than 40 in males or 35 inches in the woman. That is heightened. And this is one of the components of metabolic filtrum. And if the hips are higher than 90 in the male and 85 in the woman, that means that the risk is heightened. And what happens with this is that we have to create a variation, create a classification uh, for a bias and home. And regardless of this, I can, uh, without taking into account race or sex, I can identify who is at a higher risk. If I have more than zero point 0.5 in this quote, I have a higher risk. If it's 6.7, it increases the risk for cardiovascular and cardiometabolic issues. So we only have to have, you know, just a simple tool in the office, which is a metric band. And we were talking about metabolic syndrome and the circumference of the uh, abdominal. If I have the weight circumference, if I have more than 150 in triglycerides, if I have a high HDL cholesterol in the men that is less than 40 or less than 50 in women, and higher arterial pressure of 3, 130/85, or glucose in fasting of 100 or more, that means that these are a higher risk for cardiovascular disease. And this is what I have to think about what my patient needs to do to lose weight. Basically, we need to evaluate what comorbidities are there in our patient that are associated with obesity. And the most important thing that I want you to note here is that all parameters, the sensibility to insulin, lipid profile, triglycerides, MASLD, MASH, sleep apnea, hypertension, diabetes type 2, all of them, all of us benefit if we lose 3% to 5% of our weight. And this is very important that we lead this patient that is that has an internalized stigma, we have to lead them to look at how they are improving in these parameters based on the changes of lifestyle that they are going through. Because many times the patient is not going to see a significant change in the scale. It's a patient that is bombarded by social media and everything they hear, and they see the management of obesity as something that is aesthetic. This is a chronic condition. This is a metabolic, cardiometabolic condition, and even uh, modest changes or lose of weight, 3 to 5% can offer an improvement in the parameters. And it's important that every time the patient goes to our clinic, we talk about how these parameters are going to continue to improve so that they can change their focus from aesthetics to a metabolic focus. And what are we going to do in the initial evaluation? We're going to have the screening for BMI, and we're going to use our, we're going to measure height, abdominal circumference. We have that quotient of the waist and the height. We can do the DXA, and we can see who is at risk in terms of cardiometabolic disease. And it's important to have a good medical history so that we can put aside any eating disorders or the internalized stigma that sometimes provokes depression. What are the factors that are part of the development of obesity in this patient, and what risks could come from the complications associated with a condition? Based on this, we go after some specific labs. Maybe this patient says, I'm falling asleep when I'm waiting for the light to change as I drive uh, to work, where we have some tests for that. So evaluate if they have sleep apnea, and we can also check on their hepatic enzymes. We calculate their P-score to determine if they have fibrosis, right? Because that would imply that there are changes in how we're going to choose the therapy. And everything is according to what we see in the clinic. What other things do we see? What other characteristics decide what additional tests I'm going to undertake and specific labs for this patient with obesity. And with this information, we're going to classify the level that they are at, and we're going to choose what that patient needs. Maybe it's just changes in lifestyle, or maybe there's something, another intervention from another professional of health, of behavior, of exercise. Maybe somebody that has severe arthritis, maybe we can refer them to a psychiatrist so that he can plan for exercise in lifestyle changes based on their specific needs. We can consider meds for this patient that is promoting raise in weight based on secondary causes and the development of obesity. So we need to understand what the social determinants can be affecting and how literate they are in terms of what is going on in this process. So some patients need more support from us, and we have to give it. These are some of the medications that have an effect on how we lose or gain weight. And we're going to see this further on. And once we classify the patient, we are going to start to uh, onboard this patient in a multidisciplinary manner so that we can lead this patient little by little to have a better relationship with food, determine what the plan is going to be based on their needs and likes, and to lead this patient little by little to improve their lifestyle. It's important to use a language that is appropriate, no judgment, and consider all factors that are contributing to obesity in this patient. Once we are on board with all of these plans of food ingestion and exercise, we need to monitor. Applications are a very good tool so that the patient can self-monitor and share the information with us. Some of the strategies that they can use, for example, reduce processed foods. If the patient is not prepared for dramatic changes. And in terms of the strategies for monitoring, one thing that we have to take into account is a patient that has a diet that is maybe not forever, less than 1,200 calories. They're going to need nutritional supplements and an evaluation for nutritional deficiencies. A lot of patients don't do this type of restriction, but if my patient has lost more than 4% per month in weight, we need to keep evaluating to see if they have the micronutrients or if they have lost 20% of their weight. In terms of exercise, the recommendations is going to be between 150 to 300 minutes per day. And aside from losing weight, we want to recommend maintenance of 300 minutes, per week. It's important to adapt all of these issues, evaluate the part of sleep, and 6 to 9 hours. And we need to be sure that there's no other issues in terms of behavior so that we can appropriately evaluate. In terms of tools, one of the things that I do is a integrated prescription of lifestyle changes where we choose at each visit what changes we're going to do, and we're going to reevaluate in each visit how the patient was able to deal with those changes, what are the barriers, and how we can modify this plan.
In terms of nutrition, I know we are going to have a nutrition later, but in general, it is very important to consider hydration when we are using medications to lose weight. In addition to losing appetite, they may also lose water. So we need to monitor the water intake because that could contribute to constipation, which is one of the most common complications of these medications that we more frequently use, which are dual agonists or a GLP-1. So this is important to ensure that they have a varied diet with different macronutrients, that we incorporate healthy fats, and then we have an adequate intake of proteins. In terms of exercising, it's important to have resistance exercise. For women, the diets are usually between 1,200 to 1,500 calories initially, and in men from 1,500 to 1,800 per day. And it's important to keep in mind added sugars. And this is based in what are the preferences and needs for this patient. And it is important then we need to do that recall to see what the patient isn't taking, because many times the patient is eliminating whole groups of food or restricting foods to some very specific food, sometimes because of the side effects of medications that they are taking, and those are important signals that we need to identify. In terms of medication, we have the festormin for to manage obesity, but this is short term, and we have listas that could be used long term, phentermine and topiramate that could be used long term, naltrexone or bupropion long term, and what we have at the end of the list, which are the GLP-1 agonists and dual agonists, which are producing more weight loss. And here I am missing orforglipron, which is the last one of these medications that has been added to these medications. And the study related to this medication, I think it is the only one that we have not discussed. It is called ATTEN-1 that gave the approval for managing obesity. Different to other medications, this GLP-1, this is a small molecule that could be taken at any time. It doesn't require to be fasting, and they can take it at any time during the day. In terms of weight loss, the medications obviously with more effect in terms of percentage of weight loss are the GLP-1 receptors and the dual agonists. And in terms of side effects, in terms of phentermine, we need to be careful in patients with established cardiovascular disease, with glaucoma, or with hypertension. This is really important. In the case of Orlistat, it could have, we need to be careful with vitamins which are soluble in fat. In the case of terpinomide, it is, we need to be careful with women who may be pregnant or in reproductive age, and also those with cardiovascular disease and propionitis. We have some, we need to be careful with people who have hypertension that is not controlled. And we also need to take into consideration the medical history in terms of thyroid cancer or with pancreatitis. Also, patients with a history of gastroenteritis. We need to take into consideration all these factors with these patients. So you can take a screenshot of this slide. And here we have all the medications with the dosage and the approximate weight loss produced when taking these medications. So in terms of titration, most of them are titrated the same way. The phentermine Taramet, when the initial dosage, it is very important to monitor the response. If the patient will have a weight loss of 5%, we consider it as a therapeutic failure, and we should not continue with therapy. In terms of how we are going to select the medication for obesity management, and this is determined by what conditions, what comorbidities the patient has, and the American Association of Clinical Endocrinology provides particular recommendations for those patients with diabetes, prediabetes, metabolic syndrome, and they prefer the GLP-1 antagonist. When type 2 diabetes, they add phentermine with topiramate. In CKD, semaglutide and tirzepatide, but they have an indication by the FDA for patients with established kidney disease, the semaglutide, and in patients with MACE and may have infarcts, we consider the GLP-1 antagonist as the first line of treatment. And in this case, those that have the FDA approval are semaglutide and liraglutide. And in hypertension, also dual agonist or GLP-1. In heart failure, HFpEF semaglutide, we have more data, osteoarthritis, semaglutide, and OSA. Here, we have more data for fermenting topiramate, tirzepatide, that have indications by the FDA for patients with sleep apnea, which is moderate to severe. In terms of how it's going to be titrated, the GLP-1s, usually it is a recommendation of a titration not fewer than 30 days, but the golden rule for these medications is a slow titration, trying to use the same dosage while the patient is having a weight loss. And if the patient gets to stop, then we need to evaluate the caloric intake, the nutritional composition, and to evaluate the exercise plan before determining any change of the dosage. As I tell my patients, each of these dosage is a sleeve under a card under your sleeve, and we need to uh, try to keep this as much as possible to be able to produce and to keep this weight loss. And also this slow titration is going to help this patient to little by little improve the relationship with food and to better adapt to these changes in lifestyle. In terms of side effects, the most common are gastrointestinals, and also we need to keep an eye if there's a rapid weight loss in pancreatitis. Honestly, I have not seen any case. We have seen an increase in cardiac, and but mostly in people with therapy with insulin, and the recommendation would be to reduce the insulin and to continue with collarelia. The contraindications we already mentioned. It's important during pregnancy when we start this GLP-1 or dual agonist. These patients in contraceptive therapy, they should use a barrier method. And every time they increase the dosage for a month, they should use a barrier birth control to prevent pregnancy when we are taking these medications. It's also important that we need to detect overdosage. Sometimes maybe mistakes in administration. It happens mostly in patients who are taking compound medications that are not recommended to use this kind of therapy. And this is reserved for patients who may have any kind of intolerance to any medication that are approved. And there are many alternatives, many dosages. So there is no need to use these therapies. But those who are using, for example, injectable medications, some of them come in a vial. They're more propense to have errors in administering when there is self-medication. Also, many people without the criteria, they're taking this medication and they have a titration without regulation. And also there's a lack of knowledge on how to use the device. And my recommendation would be, if possible, that first dosage should be administered at the office. We usually receive samples for these medications, so we may have the dummy pens for administration that we could use to educate the patient on how to correctly take and use these devices and how to discard them safely. The most common symptoms are nausea, vomiting, 92%, hypoglycemia, and especially when they are using diets with high restriction of carbohydrates, and these symptoms may last 8 to 24 hours depending on the particular case. And how can we prevent this? Showing them how to use it, to verify that they understand what is accurate dosage, to ask them to inform any new medication or supplements or changes in eating. Sometimes they use nutraceutical elements to try to reduce sugar, and all these things may contribute to this development of nausea. It is also important, we need to tell the patient that everything they are going to take, they need to verify possible side effects, even though they tell you that they are natural, and the correct word is ultraceutic. And we need to follow the approved titration schemes. They shouldn't have too fast titration of medication, and always we need to document what dosage the patient is using. And if possible, to give the written information to the patient. We need to evaluate gastrointestinal symptoms at every visit. If the patient is increasing gastrointestinal symptoms, we need to go back to the previous dosage. That's the best recommendation before we have a situation that could be more compromised. And we also need to check the glucose in some cases. We are going to administer IV liquids. We need to monitor glycemia, and we need to observe the patient 8 to 24 hours, depending on the severity. And we need to evaluate all the situations. These medications, they don't have a specific antidote, and the symptoms may last days. So we need to provide therapy support. And in conclusion, the key messages are: first, that obesity is a chronic disease, a cardiometabolic disease, with not only one risk factor, but it is a condition uh, with multiple factors. This metabolic syndrome is going to double the severe risk. and to multiply the DM2. And we need to take measures to reduce the weight to prevent that progression. We need to evaluate that visceral adiposity, and the GLP-1 agonists are the best pharmacotherapy. And we also have the select study with 20% decrease of MACE in patients with cardiovascular disease. And also the interval management requires an intervention taking into consideration behavior, nutrition, and exercise, and according to the characteristics of the patient. So that will be all on my end. If we have any questions. Thank you, Dr. Hernandez. And we are going to leave the questions for later. We are going to save the questions for later. And we are going to email you the questions so we may continue with Miss Keyla Hernandez, licensed nutritionist. So Keyla, if you're able to hear us, please go ahead. And thank you so much, Dr. Hernandez. Please write down any questions that you may have, and you can type that on the chat or email us your questions so we may forward your questions to the doctor. Good afternoon. Nicole, I don't know if you can hear me and if I can see my screen, or I'm not sure if you can see. Yes, we can see a browser. And on top, okay, now allow me just a moment, please. Now, yes, now it is showing us presentation. Perfect. Good afternoon, everyone. Thank you so much to the Institute for this program that you are having for people in healthcare that are interested in keeping up to date with all this information. Dr. Hernandez already gave a lot of information about all this about obesity. So I am going to focus more on nutrition. At the beginning, I am going to talk a little bit more about obesity, but we are going to focus more on nutrition since Dr. Hernandez already covered a lot of information. So it is a nutritional intervention in diabetes and obesity, but we know that there are comorbidities that are related as well. It is important that to let you know that I don't have any conflict of interest, and within the objectives, we are going to be talking and updating the nutritional management of diabetes and obesity. We're going to apply evaluation tools for the BMI and to individualize treatment according to the comorbidities. We want to prevent muscle mass loss, which is so common in these conditions, and also the nutritional deficiencies, and also to implement practical strategies that you could use in your practices and in primary care health. And why nutrition as a key treatment when we're talking about an interdisciplinary approach? Well, we have seen that it improves the adherence to treatment. So if the patient is in a pharmacological treatment, if they have in a caloric deficit, depending on their treatment, we have seen that nutrition is a pillar in the results and also in adherence. Also, we can increase the benefits of pharmacotherapy. We see better results, and we also encourage sustainable changes in lifestyle, and we decrease the risk of complications, hospitalizations, etc. And why more than BMI? Well, we have seen that beyond obesity, it is not only defined by BMI, but we have a multidimensional approach where we include a combination of BMI with other measurements to take into consideration adiposity. So obesity is not only a risk factor for chronic diseases, but it requires continuous follow-up. It is multidisciplinary. We need to confirm take into consideration BMI and other measurements. We need to individualize the nutritional treatment, which is so important because each person is going to have different requirements in terms of calories, also taking into consideration their preferences. If the person, the social aspect, the person lives by themselves, if they need help, if they receive assistance, if they have transportation, if they have financial assistance or not, everything that they have available, we need to take into consideration all of that in our nutritional plan. And we also need to have a priority in cardiometabolic health, and we need to preserve muscle mass as a priority during weight loss. Before, how we were seeing this in terms of obesity and its management? Well, previously, BMI was the most important thing to see if a person was overweight, and currently we take into consideration BMI in addition to other measurements to combine it and to take that into consideration for the results. Before, we only thought about losing weight, but we didn't take into consideration other factors. So now one of our goals is to improve the cardiometabolic health. And before we talk about a diet, and now we talk more about an individualized plan, taking into consideration all of this. Before, we were talking a lot about counting calories, but currently, mostly we are seeing the quality of the nutrition and the adherence because it is not the same. I am going to prefer to intake calories from fish or a lean protein versus a pizza, for example. So it is not the same evaluation or the same requirements that we are seeing currently. Now we are seeing in a more holistic way, and we are taking into consideration the quality of those calories versus in the past when we were encouraging people to count calories without really seeing the origin. So before we were more talking about losing weight, and now we want to preserve muscle mass. So we are giving a lot of priority to this. And before we were taking medications like now, but we didn't give a lot of emphasis like we are doing now about nutrition, stress, resistance in combination with medication, and to continuous follow-up. And before we saw obesity as a risk factor, and we may see that after so much research, it is evidence that it is a chronic disease. The current guidelines, they suggest that we may combine, and we could continue to using BMI, but we need to combine it with an additional measurements to take into consideration all the factors, and we may have a more wholesome assessment of obesity. Dr. Hernandez mentioned some of this. So we also need to take into consideration height and weight, but when we measure the waist circumference, when we're going to measure women, should be less than 35 and men less than 40. So we have a less risk of developing cardiometabolic disease. So I wanted to see the relationship between the rates for weight and height. So if you have an stadiometer in your office, it happens to me that the patients, they have not measured their height in a long time. And when I measure them, it happens a lot that their height has been changing. So for young people, I always measure them. And for older people, I always measure them, their height. When they are in an adult age, I measure them in certain appointments. But usually young people and elder people, I always measure them, and it changes a lot. So we always need to measure height, the waist circumference. I use this measuring tape. It cannot be any measuring tape. I can give you the information about this one. So we have that evaluation, and if it is over 0.5, and we're going to discuss a hypothetical patient. If it is over 0.5, they have a higher metabolic risk because the patient is accumulating more adiposity, visceral fat. So we may have a patient, and before we call them according to their shape, like a pear-shaped patient. So we may have a patient who is short, and the example that I have is 5'3", but in that case, we are going to notice that the patient has a height of 5'3" and a 35 inches waist circumference, but since they are 5'3", the risk for cardiovascular disease is going over 0.5. And in number 4, we have bioimpedance. So we take into consideration if the patient we if the patient exercise, if they have exercised before, if they are hydrated. So it is not so certain. So it may be a useful tool, but we cannot trust only that. And that's why we always recommend to have at least 2 or more measurements to evaluate the patient for that continuous follow-up. Here we have the hand grip, and this has been used for many years in multiple studies, and this is one of the most used to evaluate the risk for sarcopenia. So we evaluate hand grip and also the uh, disability and hospitalization and mortality risk. So for a woman or below 16 is a higher risk of sarcopenia, and in men below 27. In the SARC-F test, this is a screening that also allows to identify patients with a higher risk of sarcopenia. It evaluates strength, if they need assistance to walk, if they need assistance to get up from a chair, how they are climbing upstairs, and how many falls they've had. And over 4, it is a higher risk for sarcopenia. And the EOSS, Edmonton Obesity Staging System, we already have a diagnosis for obesity, but it classifies how serious it is. Taking into consideration all these risk factors, metabolic complications, physical, psychological. So this could increase the severity of the patient. So we have stage 1 to stage 4. And we have a hypothetical case that I mentioned before. This is a lady. She's 52 years old. Her waist circumference is 35, but her height is 63 inches. So we calculated and we have 0.56. So she's very close to borderline, but she's over. So she has a cardiometabolic risk that is increased. The evidence continues supporting that preserving muscle mass could really increase or improve the cardiometabolic results. And in general, when we're talking about a patient with, for example, with kidney disease in stage 4, for example, we need to take into consideration and also the lab work when we need to restrict protein, for example. But in general, some clinical strategies that are used during obesity treatment, we use from 1 to 1.5 grams per kilograms of weight. It is adjusted and individualized, obviously, and the distribution, calories are very individualized. In my case, I don't go below metabolic basal metabolics. So we need to keep an eye very close. And for patients the guidelines, they may tell us that 30 calories, 25 calories per kilogram of weight, or however you're going to compute it. But the patient, they are not taking what is recommended. So in that initial evaluation that I may be over an hour with that patient, learning about their history, what they like, what they do. We talk a lot about, I get a lot of information, or maybe 30 minutes in a follow-up visit. That's when the test that you do, the frequency, the journal, the app, all that is used to see a more real intake for the patient. Many times you realize that the patient is not, uh, their intake doesn't reach the basal metabolism, so it is not real. So we need to evaluate other aspects to see where we're going to align these caloric recommendations to gradually increase it or decreasing that caloric intake, giving orientation to the patient and seeing what they are actually taking.
We can omit food. We need to consume protein in each one of the main meals, and we evaluate if they're not using protein in the main meals and they're only snacking. We need to reinforce that snack so that it looks more like a meal, so that it's not just a snack with only carbohydrates or fat. In terms of exercise, we emphasize a lot in terms of strength, 2 or 3 times a day, that type of exercise, and at least 150 minutes initially per week, and then for maintenance, 200 to 300 per week. And that's something that we individualize a lot. Maybe sometimes the patient has never done anything for exercise. So we have to start with 15 minutes in the morning, in the afternoon, or 15 minutes a day. And the physical activity that we need to do, we have to, if it's, if it's dancing, it's dancing. We need to use elastic bands so that we can integrate strength exercise in terms of the loss of weight. We need to prioritize the loss of fat and minimize the force, the loss of muscle mass. And we have to constantly monitor uh, the BMI and, of course, height, waist, and bioimpedance and the circumference of the waist. Hydration is very individualized. Some patients tend to lose a lot of the consumption of water, so that has to be a priority, and we have to take that into account because that is very related to diminishing the muscle mass if they don't have enough liquid. And we're talking about not only obesity, but cardiometabolic situations. So we have to see if we need to restrict liquid, if there's edema, if there's a kidney condition, we have to take that into account when we're doing this. And we also have to work in this interdisciplinary.
No es que le vamos a retirar los carbohidratos, no van a eliminar los carbohidratos. Aquí vienen muchos pacientes
talk about that. So we have to talk to them. We have to talk to them in each one of the consultations so that they understand carbohydrates, what is better in terms of carbohydrates, what has to be our priority, and what are the benefits to the patient. In terms of cardiovascular issues, we look for the DASH and Mediterranean, so reducing sodium for weight control. Hepatic and gastro, we are looking for fiber, hydration, Mediterranean pattern, small meals in kidney ones, individualized protein, sodium, potassium, phosphorus, according to the lab. We see how to work on these minerals and the protein and hydration. When we're looking to muscle, skeletal, we are working with protein. We need to reinforce with the adequate protein, vitamin D, when it's needed if we find any deficiencies, and of course, strength exercise. We need to evaluate that, use the results, and whatever's indicated, that's where we specialize and individualize. And in terms of mental health, we have to center education on the patient. We have to use interdisciplinary tools, and we have to know that many conditions are related to mental health, especially obesity. And when patients start with this type of treatments, this management, be it medication or caloric deficit, we need the help from a psychologist, and that have a patient that is available and willing to include a psychologist as part of the interdisciplinary team so that we get better results. Because in my office, I have some psychologists, and since we started doing that in my office, I've had a lot of beneficial results for the patients. In terms of the gastro health, the digestive alterations can affect how we manage food, the adherence to treatment, and the results that we get in terms of the cardiometabolic results that we're looking for. And we can see here in terms of this gastro health, when we're talking about fatty liver that could be impacted, and it the risk goes up with fibrosis, hepatic disease progression, cardiovascular risk. We focus a lot in the reduction of weight, 5 to 10%, whatever the case, the Mediterranean diet and exercise. When we see the ingestion of fiber, we know that we are dealing with the clinical impact on having difficulty going to the bathroom, the glucose, dysbiosis. So we need to have 25 to 38 grams a day of fiber into whole foods and adequate hydration. The microbiosis can be affected in the metabolism and the response to the treatment. So we're focused on fiber, legumes, and fermented foods. When we're talking about medication, we've seen that there's a diminishment of intake of protein. The risk diminishes in state of or heightens sarcopenia, and we know that this has an impact on muscle and the liquids and micronutrients. So we need to focus on protein, hydration, and small portions, as well as exercise. When we have patients with ERGE, they tend to stop eating and they are using medications, they have reflux, so they eat less, and sometimes they abandon the process because they have different gastro symptoms, and that's why they have reflux. So we talk about small portions, uh, free of irritants, better habits, and of course, controlling weight. And that means that how they sleep, how they chew their food, etc. And when they're having difficulty going to the bathroom, of course, the clinical impact is that they have pain, abdominal distension. They don't go with the treatment because they don't feel comfortable. They don't feel well, and they abandon the treatment. So we need to have a lot more fiber, hydration, and physical activity. And what are the nutritional deficiencies that we tend to see more commonly when we have hypocaloric diets, when we have prolonged fasts, when we have restrictive diets, when we have medication to lose weight? Well, the protein, there's you feel full earlier, so you tend to consume less. And that means I need to try to eat the protein first. And sometimes I can't use the whole plate. And what happens is that sometimes what they eat first is the carbohydrate instead of the protein, and that has uh, less consumption. And of course, less muscle mass, less strength, higher risk of sarcopenia. So we need to promote strength exercise. We refer to a nutritionist. It's not enough to raise or increase the consumption of protein. It's important that the patient understands ideas of how to integrate protein. Sometimes they don't want to have breakfast, but we need to see how they can integrate protein. Uh, Sometimes as part of their foods. It's we need to find what they like, what they prefer. They don't want to consume animal protein, and so we need the help of a nutritionist. Vitamin B12, medications, bariatric surgery, element foods, and a diminution of consumption of animal food sources. Uh, B12 can be affected. It can have or lead to anemia, neuropathy, cognitive deterioration. So we have to evaluate B12 and uh, use a nutritionist to supplement if that is needed. In terms of the iron, that is a very common deficiency, and it decreases when the use of or ingestion of meats decreases. So we have to be very aware of all of these things, and you need to use a nutritionist, use it. In terms of deficiencies in fiber, and this happens, and it's because they don't eat as many vegetables and fruits and of whole grains. So this is one of the medications that is most often used, and this can lead to difficulties going to the bathroom. They don't feel satisfied. We need to refer to a nutritionist so they can use those 25 grams of fiber a day and adequate hydration. In terms of vitamin problems, that has to do with obesity, as I mentioned, and the decrease of consumption, and it can have an alteration in your um, a skeletal and muscular health. It can have an impact in mental health. We have to check the metabolism. We have to evaluate. We have to find the risk factors, and we have to look for that dietitian to, through foods, exposure to sun, and continuing seeing this patient take their supplements. This is salvage. And zinc has been seen, this is being studied a lot because when we diminish the consumption of animal proteins, and we see it with medication that the patients present not only a decrease in the consumption of protein, but they start losing their hair. Their taste is not the same. They have trouble with their scars and how the body deals with that. So, uh, this is usually the suspect number one when we are losing uh, progressively weight, and we have limited congestion. As I mentioned before, in terms of the evidence in the nutritional area, the nutritional or eating plan that we recommend with evidence is the Mediterranean plan. This is elements, foods that are not processed or minimally processed. It's rich in healthy fats, fiber, and proteins. So we're looking for that. This is not new. I really like that these diets are being offered. As I mentioned, foods that are minimally processed, rich in healthy fats, fiber, and proteins. The DASH diet is good for bettering uh, blood pressure, cardiovascular risks, reduction in sodium and saturated fats. It's rich in potassium, calcium, magnesium, and fiber. And plant-based diet that is totally different. It is a vegetarian diet, etc. This centers in vegetable based foods rich in fiber and bioactive uh, comps. Um, Before going on, we need to mention that this is a general guide based on diagnosis, but sometimes we have to combine several of this. We have to adjust, and that's why we have individual plans. Because if it's a Mediterranean or DASH plan, what are we going to use from other areas because of the patient tastes, needs, preferences, comorbidities, among other things that we have to take into account. Important data. Not all of the lost weight represents fat, and this is something that we have to remember, emphasize. And if we have a way of measuring, that's good. BMI is not enough. We need to preserve muscle as a priority. Nutrition improves the efficacy of the pharmacological treatment. The quality of the loss of weight is more important than the quantity. We need referrals early on to improve results. The interdisciplinary treatment with an endocrinologist, nutritionist, diabetic educator, psychologist, and physical activity. And of course, everything centered on the patient. I know that I'm going a little bit fast because of time, but I hope that all of these references and the information provided are of help to you as we spoke about the applied practices that we discussed so that you can start integrating in the daily work that you have with your patients. Thank you, Keyla, for your excellent presentation. And now I'm going to go for the post test. You're supposed to be able to see it already in your screen. I'm going to show it on the screen again. Give me just a second and I'll be able to share it. Okay. And you can answer the post test. You can scan the QR code, or you can use the link at the chat. Any of those ways will allow you access to the post test. And due to time issues, we're not going to deal with questions right now, but you can put them in the chat. And I see that Dr. Leticia was able to answer some, and I want to discuss the clinical case. So, Franceli, go ahead with the case. Hello, good afternoon, everyone. I'm going to go into this. We have a male patient, 79 years old. He's retired. He only receives Social Security and a SNAP. The medical history shows that they are at a stage level kidney failure. They have diabetes for more than 30 years. They have 3 tenths for cardiovascular for 10 years, angina pectoris, nitroglycerin, sublingual. They have damage to their spine and losses to their motor skills. They have depression, anxiety since they were young. They're alone and they constantly feel pain in their body. They don't want to eat. They've lost 10 pounds in less than 6 months approximately. They just use omega. They are very sedentary and participates in certain things in their elderly center. Physical tests, 162 over 69, 58 per minute, saturation 98. He weighs 145 pounds. His height is 5'2". And we have other vitals, 135 over 79. Uh, we have pulse at 71, temperature at 36.5. We do the physical exam of the abdomen. We see that there's inflammation. They had recent surgery and biliary drainage. He's tympanic in the stomach area and has some issues in the area of the liver. They have edema in the feet, uh, dehydrated, and they've lost some of their nails. They're members of 24 hours. Breakfast is 8 a.m., lunch at 12, uh, last meal at 4:30, and a snack at 9 p.m. So he eats white rice, beets, chicken, um, potato, bread, eggs, cheese, ham, cookies, coffee with milk, 1.77 liters of water. They have x-rays and there's a gastric problem there. And he has this clinical diabetes. We have kidney function at 30, uh, prostate history without cancer, cervical pain, vertebral and lumbar, cardiopathy, hypertension, arterial hypertension, diabetes. So we see the medications to the right. Uh, Buprenorphine, 10 mcg, Palmetto, 4 mg, Losartan, 100 mg daily, furosemide, 20 mg diary, finasteride, 5 mg, warfarin, 100 mg, lipicide, 10 mg daily, sodium bicarbonate, Tragenta, atorvastatina, Farxiga, Plavix, omega 3, Tamsulina, and you can see all of the amounts to your right. Next slide, we see here the labs. I'm going to leave it there on the screen so that you can check it out and come to your conclusions. We have other labs that are also available here. So we're trying to find out something here. I'm sorry, but I'm having trouble with the audio from our presenter. It is choppy and I'm not being able to see. But the question here is, what is the cost for the abdominal pain for the patient? What is causing that abdominal pain? And look at the information on the screen and we're going to another slide. Well, we have here a male, 79 years. They have recent surgery. The drainage is still there for the surgery. So what would be the cause of the pain in their abdomen? Could be some complication past surgery, and they're using an opioid among the medications, and that could create problems going to the bathroom, and that could be related to the abdominal pain. but we're also talking about a patient that is diabetic for a long time, cardiovascular disease that is established. So maybe it's gastroparesis. That's another possibility that could provoke that distension of the abdomen, because we saw that in the physical exam. So that could also be a contributor to the cause. It's important that we evaluate in a patient with cardiovascular disease that is established, that has a physical exam and abdominal pain. We have to be very aware of that connection that could be there, that could be or should be in the back of our minds as a possibility. On the screen, you will see the initial information about the patient. So I wanted to see if somebody in our audience has something to say, maybe a recommendation before we go into the comments provided by Keyla. I see that some of the comments are in the chat. Somebody mentioned GERD. This is Mariluz. I tried to raise my hand, but I couldn't find the little icon to raise your hand. Go ahead, Mariluz. Yes, I saw among the medication that he has, if I remember correctly, warfarin and Plavix. Yes, I can see it. It's there. Plavix. So those two medications, I am a nurse and I understand that obviously the doctor has to be constantly supervising. And even though he had the stents in the cardiovascular area and maybe he needs it, the question, obviously, I am not a doctor, I cannot diagnose, but I understand that it could have increased for gastrointestinal hemorrhage. So with that clinical scenario that is pretty complicated for this patient and comorbidities and all of this list of medications, I would consider an emergency that we should study more closely. Because what if this is the beginning of a hemorrhage in the gastrointestinal area? And since the patient, if I remember correctly, he still has drainage in the abdomen. I think that's what I heard. That would be my observation at this point. Thank you. Somebody's asking for the labs to see the labs once more. And here we are. Somebody says abdomen, a pelvic abdominal CT. That's one of the other uh, recommendations. Can you mention another one? Now that I see the labs, even though uh, the blood is a little bit low for males, hematocrits are a little bit low, but those are things that we should still explore, as I mentioned before, with what I mentioned before. Thank you. And Torres is mentioned it could be associated with gastrointestinal complication due to diabetes of long duration, complication of the surgery, and we recommend medical and nutritional evaluation. Thank you all for your participation and your contributions. Thank you to all. Franceli, Dr. Hernandez, Keyla, we're going to go to the satisfaction survey because we are already at the hour. You can go into the questionnaire for satisfaction, the poll, and you can please fill that for us. We would be so appreciative. While you're answering that, I want to remind you that we have a digital bookstore, recursos.prht.org, where you're going to find today's session. And I want to let you know that we're going to have an additional session, nutrition when considering cardiovascular and hypertension risk. We're going to have once more Keyla Ortiz. It's going to be Wednesday, July 22nd from 3 to 4:30. And we're going to discuss her experience. We also invite you to submit a case from one of your patients. You can see in the Echo platform if this is already in our scheduled programs, and maybe you can submit cases for any of the next programs that we're going to have. We also have another Echo that is specialized in the management of the use of opioids and pain management. This is in English. We don't have interpretation here, but we're going to have it next week. I'm sorry for the date. The date is wrong in the slide. I understand that is on next Wednesday, on the 15th of July, from 12 to 1:30 p.m. So thank you so much for being with us. We hope to see you next time in our next session. And as always, please keep an eye out for our emails that you're going to be receiving with reminders for our next sessions.